Welcome to Direct Supply's Continuing Education webinar series. Direct Supply offers monthly webinars on a variety of topics throughout the year. The topic for today is dysphagia management, combining traditional treatments with NMES and surface EMGs. My name is Robin Malik, and I'll be facilitating today's meeting. Please note the information contained in this presentation is intended to provide general information but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today's webinar will be presented by Lindsay Douglas, the Director of Clinical Education at Spectramed, LLC. Lindsay completed her bachelor's and master's degree at Missouri State University. Her clinical background includes medical SLP and managerial positions in long-term care, rehab, and home health, with extensive experience in geriatrics. Lindsay has taught continuing education courses in geriatric dysphagia and other topics across disciplines for the last 8 years. She values continuing education as evidenced by her ACE Award from ASHA in 2017. She has particular interest in the implementation of modalities for improved dysphagia outcomes. And now, please welcome Lindsay.
Hello, everybody. Thank you so much for joining us today. I'm excited to be here, and thank you to Direct Supply for having us join you today. What we're going to be doing is sharing just some general information, just like Robin said, about dysphagia management. And then we're going to talk about how can we combine what's already in our toolbox, our traditional treatments, with some additional modalities. And today, those modalities that we're going to talk about are both NMES, or neuromuscular electrical stimulation, and surface EMG, surface electromyography. And so we'll talk in detail about those as we continue on a little bit with our course today. I do need to quickly disclose, per a couple of continuing ed requirements, that I do receive a salary from Spectramed, LLC, that's my employer. And then my non-financial relationships are that I am in several special interest groups through ASHA, and I'm a member of ASHA. And you can see here, I participate in the swallowing and swallowing disorders group, as well as the voice and voice disorders group. By the time we're done today, over the next hour, we hope that you're going to be able to explain just some of the physiological changes that happen with our swallowing as we age. And it's important to really be able to identify what's normal so that we have a better idea of how to identify what's abnormal for many of our patients that we see. We also want you to be able to identify and to discuss the tools that are available for dysphagia management. And then we'll be more specifically discussing the application of NMES and sEMG in the treatment of dysphagia. So before we get too far into what happens with the swallow and dysphagia and that breakdown, we want to take a moment and we want to talk about how many of our residents or patients are impacted by a swallowing disorder. So deglution, we'll start with some basic definitions. Deglution is just the act of swallowing. And you're going to see here that it begins at the mouth and it ends at the stomach. So all the way from the moment we put that sip of that drink or that bite of food into our mouth, all the way until it enters our stomach. So tell me, I want you guys to think about it. How many times do you think we swallow on average every day? And you can just put that right there in that chat box.
5 times.
And so you might be surprised that we actually swallow around 1,000 times a day. And so if we're talking about small infants, that increases to around 2,200. But on average, somewhere around 900 to 1,000 times a day. So that's a lot of opportunities for there to be some type of breakdown, for something to go wrong, and for our patients to be at risk. So I want to take a moment here. We have just a really simple video swallow. This is under video fluoro of a patient that is quote-unquote normal. They're not having any abnormalities or any concerns, but I want you just to take a quick look at it. And so what you see here in this video, it happens very quickly. So that's one, is that it's very fast. It's also a highly integrated set of movement patterns. It's safe, it's quick, it's efficient, and all of these different muscles and all of these different things have to happen very quickly so that the bolus, that little sip of liquid, is cleared. It's away from the airway. There's no residue. And for a swallow to be considered normal, we have to be able to do this with multiple successive sips, with large volumes, and without any type of hesitation. We often break our swallow down traditionally into 3 different stages: the oral stage, the pharyngeal stage, and then the esophageal stage. More recently, our field has really went to discussing swallowing in more in terms of physiological components. And you can see here, just from viewing this video, how complicated this can be even when our patient doesn't have any type of impairment. So dysphagia then is any type of impairment that happens anywhere between the mouth and the stomach. And because it is so complicated, our patients rarely have only one isolated issue. And that's why being able to view their swallow on instrumentals, like here on the video or on a modified barium swallow study, can be very important for our plan of care and really getting the best outcomes. I've got here some signs and symptoms of dysphagia. These are some things not intended to be a comprehensive list, but really to give us just a quick look at some signs and symptoms that we could use for education, for our staff, for caregivers, so that we're able to identify if our patients or our residents may be having issues and making sure that we get those referrals over to the speech-language pathologist. So coughing and clearing of the throat, that's probably the one that's the biggest red flag that sends those referrals over. If your patient has an abnormal volitional cough, so you ask them to cough on command and it sounds really weak or abnormal. Changes in vocal quality. So for this one, it may be, you go through the dining room and you tell Mrs. Smith, hello as you're walking through at lunchtime, and she's just taken that sip of coffee. And then her voice sounds wet and gurgly, like she's underwater. Recurrence of chronic respiratory illness can be a sign. Patients having to take multiple swallows to get that liquid or food down. Patients that take a long time to eat. And if we're seeing frequent low-grade fevers and maybe we can't figure out what's going on there. Or what's known as globus sensation, where you feel like something's stuck right here in your throat, like you can't get it down. And often that's actually a deferred sensation, and it may be that there is residue or something lodged further down in the esophagus, but because of the innervation, we're feeling it right here in the middle of our throat. Of course, diet modifications, difficulty starting or initiating that swallow. If we have spillage of food or liquids from the lips or difficulty managing saliva, regurgitation during or after meals, and then we know that weight loss and dehydration can actually be a symptom of dysphagia. Now, as far as consequences, we know that dysphagia, or having a swallowing disorder, can be pretty severe. It can have some effects for our patients' overall health, and it really can have a snowball effect that gets set into motion with an overall decline. So you see here coughing and choking. You can see here with coughing and choking that there can be.
Lindsay, I'm just going to interrupt you for just a second. If everyone could please mute their lines. We're hearing some background noise, so if everyone could mute their phone lines, we'd appreciate it. Thank you.
Thank you. So if our patient is exhibiting a lot of coughing and choking, not only is that a sign and symptom, but it's also a consequence, and we know that that can really decrease the quality of life or the mealtime quality for those patients. Chronic respiratory illness can be an issue. Dehydration, malnutrition, that malnutrition can lead to weight loss. Formation of decubitus ulcers or wounds can happen due to our patient not getting those nutrients they need. And then in the worst cases, a patient can unfortunately die from all of the effects or the consequences of dysphagia. So we want to be able to really identify that and get in there and see what we can do as professionals to rehab that patient's swallow. So a couple of statistics here. About 1 in 25 adults presents with dysphagia. And we know that number may actually be a little bit low because not all cases are reported to their physicians or their care providers. We have about 10,000 individuals that are baby boomers that are turning 65 every day. And you're going to see here in a moment how aging actually does impact our swallow even when we don't have other comorbidities going on. About 38% of long-term care residents have some symptoms of dysphagia, and 13 to 38% of the elderly individuals that are in inpatient facilities present with some type of swallowing disorder. You'll also see 25 to 45% of typically developing children have some type of swallowing disorder, and then that increases to 30 to 80% with individuals, children that have developmental disorders. These all come from ASHA and from some other current research articles. So you can see that if you're in an environment or a facility, a setting where you have a lot of patients that are geriatric, you're going to see some widespread dysphagia, and we want to make sure that you can identify that, and we also want to make sure that you have some ideas about what those referrals to speech pathology might do. So we're going to take a moment then, now that we know the individuals, kind of how many folks are impacted by dysphagia, we want to take a look at what happens. I'm going to play this very simplified video. So what this is doing is kind of breaking down the act of swallowing, and then we're going to do the same thing. We're going to talk about it just kind of in simplistic terms and kind of get an idea, again, a closer look at that video fluoro, that video that we looked at the beginning. We're just going to talk about that in a little more detail. So as we look here at our individual that's swallowing, I want you to think about all of the different processes that have to happen. And right now, we're just going to break it down, thinking of it kind of like valves, things that have to close and open. Now, we already know that swallowing is a lot more complex than that, but I just want to point out a couple of things that really have to happen for the safety of our patient. So, of course, the first thing that happened with our patient here, we'll say this is Bob, okay? Bob had to take that cup, and he had to put it to his lips, whether he was taking a drink via straw or cup. He had to take that drink, okay? That's really the first step, is getting it to your mouth. And then you have to seal your lips. So play along here with me for just a moment. And I want you to pick up that coffee cup or soda or that glass of water, whatever you might have handy, and very, very carefully, I want you to try to take a sip, and I want you to leave your mouth just slightly open, your lips just slightly parted, kind of like what you see here in this picture. And then I want you to tell me in the chat box, did that make it harder for you to swallow? What did you notice? I see a couple of folks saying it was a little harder to get it down, harder to get that swallow to start. Some people had some issues. I hope nobody drooled coffee down your shirt. Sorry about that if you did. Okay. Now I want you to think about just a typical patient that you might come across who's had a CVA. And because of that CVA, we have some weakness in the cheek, some issues with facial symmetry, some drooping, and that patient's lips don't seal. Based just on that, not even thinking about the rest of the swallow, we know that that individual may have difficulty swallowing because they can't build pressure. So when we swallow, we actually have to build intraoral pressure. We have to seal our lips to be able to gather that bolus and throw it to the back of the mouth with our tongue. So that movement from front to back requires some pressure. And if our lips aren't sealed, we're going to have that difficulty. On top of that, we're going to have difficulty triggering that second part of the swallow. What we talked about is the pharyngeal stage of the swallow. That's where many of you said it was hard to get the swallow going, or I had a hard time actually swallowing with my mouth open, okay? Now, we don't have any other impairments. We don't have muscle weakness. We haven't went through any issues with disuse. But just because we didn't seal our mouth, we had trouble swallowing, okay? So really start to think about how just small issues in our patient's anatomy or small issues because of some type of neurological breakdown or some type of weakness can really impact more than one part of their swallow and really impact their overall safety of their intake. Now, after we sealed our lips, after we took that drink, we sealed our lips, we moved that drink from the front of our mouth to the back. Then we saw that movement here at the top, okay? That's velopharyngeal closure. So I know for those of you on the call that are SLPs, this is a very basic review. And for those of us, I just kind of wanted to give us all a little bit of a foundation for what we're talking about here in a moment, so that we have to have the velum has to move up and seal. And again, that's creating pressure, and that's keeping anything from coming through and regurgitating through the nose. Once we have that seal, we have epiglottic inversion. Now, this is often an issue when we do get back those reports, when we've sent our patients out for swallow studies, or if you're lucky enough to have one of those mobile companies come into your facility. On the report, it says poor epiglottic inversion. Well, epiglottic inversion, the epiglottis has to flip to be able to help protect the airway, and it really makes us shoot so that the bolus, that food or that drink, goes the right direction. For that epiglottis to flip, it's not made of muscle. It's mechanically driven, so it's like a seesaw. So our muscles here in our throat, our suprahyoid muscles, have to contract nice and tight. When they contract nice and tight, we have forward, upward hyoid excursion. So that hyolaryngeal excursion, everything's coming up and forward. That flips the epiglottis over backwards. So we see that inversion. Then once that epiglottis is inverted and that bolus is on its way, we need to protect our airway. So those vocal folds sitting right there need to squeeze tight together. And then our false vocal folds on top squeeze as well, protecting a nice, tight barrier for anything that may enter the airway. So again, if we're having issues here, and we see that on our report, or we have some of those signs and symptoms, and maybe we do get that instrumental, we can help work on that, or many, many pieces of the puzzle. But one, again, is those suprahyoid muscles. And by strengthening the suprahyoid muscles, promoting that forward anterior excursion, we're going to be able to help our patient better protect their airway, okay? Now, one more valve that happens as that bolus continues downward is at the top of our esophagus, our UES, or our upper esophageal sphincter. It needs to relax and open up for that bolus to enter and move on through the esophagus and into the stomach. So to relax and to be pulled open, we have to have that forward, upward movement just like we've been talking about. So those are a lot of the common issues that we may see with many of our patients, particularly with our geriatric folks. So what else do we see as a result of the normal aging swallow? Well, as we age, even without having any other diagnoses or health concerns, no comorbidities, we know that our swallow is impacted just because of aging. So that swallow mechanism, we see a delayed swallow reflex that takes longer for the patient to start to swallow. Prolonged pharyngeal clearance time, meaning there's residue in the pharynx, and then that transit time takes a lot longer as well. Now, in addition to that, as we age, we have less saliva production. We also have reduced thirst sensation and changes in sensation overall. And more than 75% of adults over the age of 80 actually experience a significant loss in their sense of smell and their sense of taste. So think about, unfortunately, the last time that you had a really bad cold, like think about a bad head cold, and you couldn't taste anything and you couldn't smell anything. What happened to your appetite? It was almost non-existent in most cases. So when our patients then are aging just naturally, we're going to see a decreased drive to both eat and drink many times, especially as our patients approach the age of 80 or so, because of that decreased sensation, okay? So we want to keep that in mind as we're working with our geriatric population. Now, what else changes? Well, unfortunately, everything starts to head south as we age, and that includes our swallowing anatomy as well. So normal laryngeal elevation for a female is about 1.5 centimeters, and for a male is about 2 centimeters, okay? And that varies, but that's just kind of an average. That comes from some research from Jerry Logeman back in 1986. And as we age, about 80 years old or so, we see that lower about 1 to 3 millimeters. And our laryngeal structures are actually noted to then lower to about the 7th cervical vertebrae. And so what that means, if you think about that picture we were looking at in that animation just a moment ago, is as you swallow, say, that sip of liquid, as it's moving through is much more adjacent or next to the airway. So the increase of aspiration actually goes up just because we age. Remember, aspiration is when then that liquid, that bolus, whatever it is, that material that's foreign, enters the airway, okay? So we can see that we really want to keep this under consideration when we're working with older individuals, which are many of the patients that we're seeing. We also want to think about common diagnoses that may result in dysphagia. And often dysphagia can be from many different reasons, but often it is because of disease processes that are impacting the brain as well as the nerves. So stroke or brain injury, patients with Parkinson's disease, multiple sclerosis, dementia, ALS, and patients that are post-head and neck cancer with those symptoms either because of the impact of surgery and anatomical changes or due to the effect of radiation and those changes. We see patients even many years after radiation that have radiation-induced dysphagia. So these are just kind of some common diagnoses that we often see resulting in swallowing disorders. So the next section that we want to talk about is assessment and screening. And I want to give you a better understanding of some of the tools that are available to us. And many of these are actually free, and there's one that can even be conducted by individuals that are not SLPs. So that first one is the 3-ounce water challenge, and that can be used by professionals on our team, even as a screening tool to indicate if a referral to the speech pathologist is indicated. And we're going to talk about it in more detail here in just a moment. Another is the clinical swallowing evaluation, which is actually built into a lot of our computerized documentation systems at this point. But the actual clinical swallowing evaluation is a set of guidelines that comes from ASHA, our accrediting body, our governing body for speech, and it walks us through each step of a comprehensive bedside swallow eval. This can be great if you're a new SLP or if you want to have a refresher. It's available for free on the ASHA website, and it really walks you through all of the aspects that we need to look at. You'll see some others mentioned here too. These are all standardized assessments, and it's important that we do have something standardized and something objective that we can document even at bedside when we do that initial assessment. ASHA NOMS is mentioned here. That's a 7-point scale, which we can utilize based on the descriptors they give us. We gather our clinical information, and then we place that patient in a particular level for swallowing. The last item I have under bedside here is surface electromyography, and that's what we're going to talk about later on today. So sEMG can be used to get baseline data in numerics, and that's going to give us something we can compare back to. So we can complete that sEMG at reassessment, at discharge, to be able to show that functional gain. You'll also see that I've mentioned instrumentals, and I did that because we do have a lot of guidance from ASHA on when we need to get these for our patients, and it does guide our plan of care, and it really gives us that insight to where the breakdown is. Just like you wouldn't treat a patient for a broken bone without getting an x-ray, we really need to see what's happening with that swallow and how that patient reacts to different consistencies and different strategies. Let's take a moment and look at the 3-ounce water challenge. You'll find all this information in detail in your participant guide that we provided today, so I'm just going to kind of quickly touch on it here. This is based on the research by the late Dr. Stephen Letter and Dr. Deborah Suter, and they've done extensive research on the validity of using the 3-ounce water challenge both in pediatrics and in adults. It is a screening tool. It is a simple pass-fail. You can see it's been validated and normed on patients on a large group, and it has a 100% success rate even 24 hours later. And what's really amazing is that it's 96.5% sensitive for silent or overt aspiration. About 60% of patients actually silently aspirate, meaning that they may very well have material entering their lungs, but they never cough. They never have any signs or symptoms at the bedside. And there's a small percentage of false negatives. You just have your patient sitting as upright as possible. You're going to provide them with exactly 3 ounces of water, and you give them the instructions, I want you to drink all of this without stopping, as if you're really thirsty. This can be conducted by admit nurses, by MDS nurses. It can be used across disciplines to really determine if the patient might be at risk and if a referral might be appropriate. This tool can also be utilized as part of our SLP assessment as just a screening aspect to determine if there might be further issues or concerns. So they pass if they can drink that whole 3 ounces of water and they don't have any symptoms, no concerns. That's a pass. A fail, on the other hand, is going to be if they can't drink all of it at once, if they have to stop, if they're coughing or choking either during or after, if they present with that wet, gurgly voice that we mentioned earlier, they show any signs of respiratory distress, or if they refuse, that's technically a fail as well. These would all you'd want to think about considering a referral to SLP services. And then also, if you want to look for more information on this, there are a lot of resources available online. either by looking for the 3-ounce water challenge, or you can also look for the Yale Water Swallow Protocol, and I'll put that here in the chat box for you. So the Yale Swallow Protocol, okay? And there's a lot, again, of published research, both by Dr. Leader and Dr. Studer. Now, I want to take a moment and just show you a quick snapshot of the comprehensive assessment. These are all important aspects that I've included in your guide as well. When our SLP goes in to do that initial assessment, we need to be really thorough. You'll see here we even mention cranial nerve assessment. We talk about alternative means of nutrition. Cognition plays a big role in our patient success, and we'll talk about how using some of these modalities can even help us with patients that can't follow directions for some of our more traditional methods. Our preferred practice patterns for the profession of speech-language pathology, which were set forth by ASHA back in '97, go into a lot of detail about what really needs to happen during that assessment. But I want to talk about conventional therapy. And you'll see this first quote here, and all of these come from several different resources, including the Langmore et al. Article that you see referenced at the bottom. But these management strategies are effective at limiting aspiration, but not at improving our patient's swallow. So much of what we do with compensatory strategies, things like alternating solids and liquids and tucking our chin, and with diet modifications, they may keep our patients safe, but we're not actually rehabbing that swallow. Now, we do have a couple of additional thoughts here about feeding tubes. And I know that many folks are really starting to get that word or read about how feeding tubes don't reduce aspiration. They don't improve hydration. And many times our patients still have the result of aspiration pneumonia because they're either aspirating their own secretions or they're aspirating that regurgitated feeding material. So feeding tubes are actually fairly costly, and one estimate looks at them being about $32,000 per patient per year. So that's pretty significant cost, considering that there are a lot of side effects that can occur and a lot of consequences. Now, I want to take a look then. Those were kind of a couple of quotes about conventional treatment, and that is a part of really our toolbox. Think of this as our buffet or our toolbox. You'll see here on the left we have compensation techniques, probably pretty familiar with those, as well as medical interventions like procedures, feeding tubes, medications. Here in the middle we have our swallowing maneuvers, which we're going to take a quick look at, and our typical oral motor exercises. Then on the right, you'll see what we term as our modalities. So this is where these are some additional aspects of treatment that we can pair with our more traditional pieces. So that's where NMES, or neuromuscular or electrical stim, and surface EMG come in. And you'll see some additional ones here as well that we won't have a chance to discuss today. So with our swallowing maneuvers and all of our pieces here, you see at the bottom, we've got oral care. So I just want to give a quick little thought about oral care and really making sure that this is an important aspect of our treatment plan for any of our patients, actually all of our patients, but particularly when we're thinking about those with some type of swallowing disorder. So with oral care, we know that it's one of the biggest determining factors of whether or not our patients that aspirate actually end up with aspiration pneumonia, okay? It's so important, in fact, if you pull out the copy of the ASHA Leader from this month, you'll see a giant yellow toothbrush on the cover, and there's a great article in there about the impact of oral care and really how when our patients aspirate any of that bacteria from the mouth, how that can result in aspiration pneumonia. Now here we've got some swallowing maneuvers and rehab techniques that you may be familiar with. We've also included these in your guide. The reason that we sometimes have difficulty getting results with some of these is that they can be fairly complicated to be able to follow directions. So let's take, for example, the Mendelsohn maneuver. The Mendelsohn maneuver is one of our only rehab techniques that's proven to help really with all areas of the swallow. It helps maintain elevation and increase elevation. We talked about how important that is, as well as improving coordination of the whole swallow and decreasing premature loss and pooling, okay? But we have to have our patient hold their Adam's apple up as long as they can after they swallow. So we have them take that small sip, they swallow, and we want them to hold those muscles in contraction as long as they possibly can, okay? Now, we can pair this with something like surface EMG. So the patient has a visual, they've got some biofeedback to be able to understand, are they following those directions? And that can also guide us as the speech pathologist during that treatment. Now, some of these get even more complicated with the different steps, and it can be difficult for us to reach patients that can't follow directions. For example, patients that may have dementia. So that's really a great aspect to bring in some of our modalities we're going to talk about because we can still reach those patients for rehab, because we can still exercise those muscles and pair it with something that's meaningful like a swallow. So again, these are some of the tools that we have at our disposal, some of our techniques. And these are all things that we use in our day-to-day treatment for patients with dysphagia. We're just going to add to our toolbox. Next, I want to talk about sEMG, or surface electromyography. What's really exciting about it, like I mentioned earlier, is that it gives us a clear, objective piece of numerical data that we can keep taking and measure back to where that patient was at baseline, when we did that bedside. It really is that external measurement, so you can attach electrodes, so we're getting the measurement from the surface, and we're measuring the muscle contraction underneath the surface, okay? So if we're using that in swallowing, we might be taking that measurement of those suprahyoid muscles that we mentioned earlier. We can also turn that data around and feed it back to our patient. So we're giving them a visual representation of the effort of the contraction that went into those muscles moving. So when they swallowed, what did that look like? Okay? So it also guides us as the speech pathologist to make sure that they are providing that effort when they're doing one of those exercises, and also what does it look like when they swallow that sip of liquid or that small bolus. Now, we have a lot of history that goes back even way before the 80s, but the 80s is when we really saw this being introduced as something that we could use clinically, okay? You'll see today that there are over 400 articles referencing surface EMG, and close to 40 are looking at speech and swallowing specifically. We see in those articles that we can use surface EMG to even identify the presence of a swallow, to analyze the timing and the amplitude, so how strong was that swallow, what was the duration, and then as biofeedback, like we've already mentioned, to give that patient some insight into their swallow and how did those muscles really contract, okay? Now, there are quite a few variables that can impact this. So when we're collecting our data for surface EMG, we think about it like we're putting on our researcher hat. So we have to make sure that everything we do is exactly the same on that first visit when we collect the data as it is when we want to reassess or when we want to discharge, if we're going to compare it back. So you see here there are a lot of technical aspects like prepping the skin and using good electrodes and getting them in the same place. And how far are they away from the skin, or away from the muscles? How far within your structure are those muscles that are contracting? And then we see the biological factors like the size of the muscle. How much adipose tissue is in that region? You know, fat cells don't conduct electricity either when we're delivering it or when we're reading it from the body. We also know from several articles that are published that the size of what our patient swallows and the viscosity, so honey thick liquid versus thin versus a bite of peanut butter and jelly, are all going to have different levels of contraction or a different number of microvolts even on the same day with the same patient. So we have to make sure that we're consistent when we set that up if we want to be able to compare that data. So surface EMG has a lot of uses clinically for us in our documentation to be able to show our progress toward goals, but it can be something great we can do with our patients, either just showing them simple waveforms and feeding that information back, and also when we use it for gamification so that we can kind of take some of the focus off of the fact that we're doing rehab and really get that patient engaged. And next we're going to talk about the use of eSTEM. So neuromuscular.
And we have one quick question that came in.
Yeah, sure.
Can you give the cost, the annual cost for the G-tube again?
Sure. It costs about $32,000 for one patient, and that's due to the complications as well as all of the feeding supplies. It's a great question. $32,000. So you see here that NMES is just one member of the electrotherapy family, okay? They're all under that umbrella term. Often it gets confused with TENS because it's a small device with an electrical signal. And transcranial magnetic is another way that we can provide it. That's really done more in research. So what we can take bedside, what we're going to use for rehabbing those muscles is NMES, neuromuscular electrical stem. You see common uses here. It's used for a lot of different reasons by physical therapy, occupational therapy, and we're going to use it for primarily muscle re-education, and we're going to talk in a little more detail about how we do that as speech pathologists. So it is simply the surface stimulation of those nerve endings in the muscles or to the nerves innervating the muscles, and we're trying to get a contraction, okay? So we can provide sensory input where the patient feels it, but there's no contraction, or we can go up to that level of muscle contraction, which is normally our target, where we're actually moving those muscles. We want to make sure that our parameters, all the bits and pieces that we program to put that signal together, we want to make sure those are adjustable and that they're appropriately tailored to the muscles that we're working with. We also want to make sure where we place our electrodes are promoting something that's normal. So we talked about that normal upward-forward movement when we swallow. So we want to stimulate muscles that provide that same movement. It's more facilitative in nature. And we want to pair it with something functional, like one of our swallowing maneuvers from one of the previous screens, or an actual swallow of a bolus or a dry swallow. We're providing muscle re-education. We can increase sensation. So for example, that patient who had a CVA that we talked about earlier that had the droop, they didn't have good lip seal, okay? If we provide eSTEM to the face, we can actually, over treatment, start to see increased sensation in the cheek and the lips before we ever see increased tone and range of motion and improvement in the motoric function. So our patient may be able to now feel that they've been chipmunking that food in their cheek, and maybe they can do a finger sweep, or at the very least they can ask for help, or as they improve they can do that lingual sweep with their tongue. So right there, before we even get to our end goal, we're already providing an increased safety of that swallow, because now our patient should be at less risk for choking, okay? We get a quicker return of function. We're able to reach patients that we couldn't reach before, and we see improved cortical mapping. So I just want to quickly show you this little video. So what I wanted to point out to you here is that normally the swallow activation or muscle contraction activation starts cortically from the brain. But when our patients have that breakdown due to injury or illness, we start to see that that activation isn't happening. They can't trigger that contraction on their own. So by using eSTEM and by stimulating those muscles from the surface, we're peripherally activating that contraction. And then we're sending that muscle to that message to the brain that the muscles are contracting. So we're actually building new neural pathways that were broken. We're just going at it from a different propagation. So we're going at it peripherally versus cortically, because cortically that patient's not able to activate or contract those muscles. We have a lot of research to support eSTEM. You see a couple of highlights here. The one study I want to talk about here is in 1992, where they did a multi-center, double-blind, placebo-controlled study, and they used Sjogren's syndrome. And for Sjogren's syndrome, there is no spontaneous recovery, and these patients often had issues with saliva production, with swallowing, and with a sensation termed as burning tongue. And in this particular study, their patients were able to return to function with significantly improved production of saliva, their swallowing function, as well as that burning tongue sensation. So there's a lot of research available. You'll see here since about 2000, there's been over 100 articles and abstracts that were published, but it gets a little bit confusing because there are a lot of different terms used, and we'll talk about that in a second. I want to briefly show you this particular study about cortical reorganization. And I'll give you just kind of the quick point here, is that after 10 sessions of using NMES paired with swallowing treatments, traditional treatments, these patients went from this amount of cortical activation at the top for swallowing to an over 400% increase, okay? And you'll see that reference in your participant guide. This particular study by Toyama et al. Gave us some great information, again, on how pairing eSTEM with traditional treatment over those submandibular muscles on our throat can actually provide greater return of function for our patient. There was another great article published in 2014 that we may not have taken a close look at because it was actually published in German. So you'll see that reference there in your guide as well. And it really gives us a good lit review of 180 studies, and the outcome or their conclusion was that it does provide a positive outcome and that the data is very encouraging for using eSTEM for both dysphagia as well as laryngeal paresis and voice disorders. So this is why it can be confusing to find the research. Lots of different terms used, lots of different methods, parameters that are all over the place. How that electrical signal is being communicated may be very different in terms of what it feels like for the patient and how it's traveling to those muscles. The length of the stimulation and how many days, and then where those electrodes were placed varies pretty greatly between studies as well. So really look at the methodology when you're looking at research. For it to truly be an NMES protocol, we have to be able to individualize it. We need it to be consistent with what we know from industry standards put forth by associations like APTA. We want it to be consistent with that normal muscle movement, something that's happening already when the body is working normally. We need a work and rest cycle, and that's going to allow us to time it with something like an actual swallow or a maneuver. And then it needs to be comfortable. No matter what, our patient should be comfortable when we're using eSTEM, okay? So we don't want anyone to lock the door because the SLP is coming down the hall. All of our patients should be comfortable, and if they're not, we need to be able to adjust that. I want to show you a quick video of what that movement I keep talking about, that hyolaryngeal excursion looks like when we're doing sEMG for a patient over the suprahyoid muscles. So as you saw a really great squeeze here, and we saw that forward, upward movement. I'll play it one more time. Okay. So again, facilitative in nature. It's what would normally happen when we swallow. It's just not maybe happening for this patient that we're seeing. So we're able to really force that movement and that contraction better than the patient could do on their own. And we're going to pair it with an actual activity. Okay.
As a follow-up to the cost estimate you gave, is there a source for that cost estimate that you can share?
Yeah, it comes from a technical review done by the Gastroenterological Society. And as we go on here in just a moment, I'll grab that reference and I can paste it in the chat box too.
Awesome, thank you. And then on the cost note, what is the cost of a person on an oral diet only per year in a facility, i.e. the difference between an oral diet cost and an alternative nutrition diet?
That's a really great question. I'm going to tell you that I don't actually know the answer to that. I'm going to tell you that it does vary greatly based on whether they're on any type of altered means of nutrition, meaning an altered diet like a pureed diet or thickened liquids. But that's a great question. I think that's something we need to add to our content. So I'll look that up for us.
Thanks. All right, and then a couple more, if that's okay. Sure. In regards to the sEMG, is it appropriate for all PTs?
Yes, for the surface EMG, the only contraindication in general when you're using surface EMG would be if your patient had some type of reaction to adhesive. So we are placing electrodes on the patient's skin. Often we're needing to secure those with some type of paper tape, something external to make sure those are very secure to the skin. But as far as, if your patient had something that you can't use it for neuromuscular electrical stim, like an example, if your patient has an implanted defibrillator, we can't use sEMG. But you could use surface EMG to provide that patient some biofeedback because we're only reading signals from the body. We're not delivering any electrical current to the body. We're just reading it. It's a great question.
Great.
Is NMES considered a form of patterned electrical stimulation?
Great question. What you're going to be doing is it's all formulated on the parameters of that signal. Different protocols, different devices are set up differently, but you should have that work-rest cycle. It's normally a biphasic pattern. It's symmetrical, and then we should have that on and off. So that work cycle where we're focusing on that contraction, and then that rest cycle where the patient can then prepare for the next facilitative activity.
All right.
And then the last one, what is the black band that was holding the electrodes in place under the jaw?
Good question. So you can use a lot of different things. You can use even a piece of Coban. That was actually a knit headband because that's a great size to go around your head. The reason that's there is we want to get really good contact with those electrodes to the skin, and particularly with our geriatric population. Sometimes we have a little excess skin that can happen. It can be really hard to transfer that signal. If we bring those electrodes up nice and tight to the surface, then we're going to get a better response with the muscle contraction. We only just had one more quick slide for us here to wrap up with the content that I'll be presenting today. This is a question I get a lot as far as, okay, what does my session look like if I'm going to be using these modalities? How does it fit into what I normally do? So you'll see this is kind of a generic example that's going to change a little across settings. But you might use your surface EMG where we're collecting that data to get some biofeedback for your patient right off the bat during your session. You can use it to collect data when it's an assessment, but during a treatment session, we'll use it for biofeedback. So maybe we're working with our patient to do Mendelssohn maneuvers and effortful swallows between sessions as a home exercise program. We can use that as some biofeedback to make sure they understand what that feels like. Are they contracting those muscles hard enough, and are they holding it long enough? And that's going to give us feedback as the treating clinician as well. Then we can go right over into NMES, particularly if you're using a device that has both, and you're going to be able to pair that SIM that we just talked about. So that was a great question right before this slide, with something functional. So a swallow of a liquid, or a little bite of applesauce, or one of the maneuvers we've talked about, so that every time that contraction is on, our patient is also swallowing, so that we're working on rebuilding those pathways along with strengthening those muscles and bringing back those sensory aspects. And then we wouldn't forget that we're also always doing patient and caregiver education and documentation and all those other pieces of our visit. So the last slide that I'm going to put up here is just my information in case you want to reach out and ask any additional questions that you didn't get to ask today. I've included our website for the company for which I work, obviously, my email, our phone number, and then we're also on social media, so there's our information there as well. So thank you so very much.
Thank you, Lindsay. We sure appreciate it. We did have a couple more questions that came in.
Okay.
Is there a time frame post-onset that NMES is no longer effective?
Ooh, that's because they are asking good questions. So we know that obviously the closer to injury, the better. If we can get a hold of that patient really quickly. Our submental muscles here, our suprahyoids, for example, start to degrade after 72 hours. So after 3 days, we're already seeing changes not only to the muscles, but to the central nervous system as well. However, there's not necessarily a cutoff point because by using neuromuscular electrical stim, we're able to recruit more motor units than we could with just exercises. Again, if we're very particular to pair it with that functional task, we can start to slowly build those new neural pathways. So we know the farther out, the longer it's going to take, but there's not necessarily a cutoff date. We really can see some recovery even quite a while after injury.
All right, thanks. And then the last question so far is, what are the contraindications again for sEMG?
Oh, for surface EMG, your main contraindication is going to be if there's a reason you can't place those electrodes over the muscles that you're reading. So when we've been talking today about swallowing and our suprahyoid muscles, if your patient is allergic to tape or adhesives, or you have concerns about adhering something to the skin, that would be your biggest. We could then think about if our patient has, any sensitivity to looking at a screen, like if you were going to use an iPad app to feed that back, that might be a contraindication. But in general, the majority of our patients can benefit from the sEMG. It's really non-invasive and can provide them with that additional input.
Thanks. A couple more came in. So why is it recommended to only do 30 minutes of NMES at a time? And how frequently should you be doing it per week for optimal results?
You guys are asking good questions. Okay, so the reason it's 30 minutes is because of the muscles that we're working with. So think about how small these muscles are here. We're talking about that group of suprahyoid muscles. We don't want to bring them past the point of fatigue. So we need to tailor our parameters in our device as well as our treatment time. The number of times a week may very much be different between settings based on what you're able to see that patient for. Often we see anywhere from 2 times a week all the way up to 5 in certain situations.
All right. We'll just take 2 more questions, and then if there are any additional ones that come in, we'll make sure we email them to Lindsay so that you get your answers after the webinar. So the next one is, would a pacemaker be a contraindication?
With a pacemaker, we need to take some precautions. So that's where you're going to work closely with the cardiologist. Again, you need to know the parameters and the device that you're using. And then in many cases, that cardiologist may want you to have them come out and do some testing from the pacemaker company, where they literally place a little magnet, read a little readout, have you do your eSIM just to ensure that there's no interference. And then you would document that as part of the chart.
All right. And then does Spectramed provide trials with a NEMS/sEMG, and do you provide certification?
So what we do provide is actually a full continuing education course where we teach you everything you do need to know about how to use the device, about NMES, about surface EMG, and about how you can really take all this as well as additional dysphagia management strategies to treat those patients that you're seeing. You do get that certificate of attendance. However, we do want to remember that ASHA doesn't actually acknowledge any certifications past their board specialty certifications. So it's really about you feeling competent. And so we do labs during our sessions, and we also do one-on-one follow-ups to make sure that you feel comfortable.
All right.
All right. Thank you again, Lindsay. We sure appreciate your time today. And now for anyone interested in seeing a demo of the Aspire 2 product, please help me welcome our awesome senior product consultant, Kelly Sullivan.
Hello, everyone. Today, as Robin mentioned, I'm going to be talking about a product called the Aspire 2. It's manufactured by Spectramed, and it uses the Guardian Way, which is a protocol we'll talk about here in just a minute or two. But I want to make sure that you have a firm understanding of some of the applications that these various protocols that are built into the system allow for you to access. First off, let me show you the product. It's very small and compact. It's going to allow for easy handheld access, very lightweight. So the actual makeup of the product itself is a product that is easy to, move around the building if necessary. If you're working with a patient, maybe in their room. In any case, it definitely is nice that it has that compact design. I will also mention that it has some benefits in terms of the type of treatment you can deliver. And much of what Lindsay was talking about, it talks to ETS, so electrical stimulation, surface EMG, which is your biofeedback tool. And then also it has an NMES as well available to you. And there's 4 protocols built into the system itself that are assigned to various different conditions. So we'll talk to that in just one second here. The product itself, as Lindsay also mentioned, has a 30-minute treatment protocol. So that is a little different than maybe what you're finding today in this particular product space. Many of which those competitor products have a 60-minute protocol. The 30 minutes, this pared down protocol allows for a little bit more of a comfortable experience for the individual. They have a lower frequency model, so it's just going to be less intensive in terms of the actual experience for the end user. The product itself, I'm going to have them get a close-up here of the product. Thank you. Has a couple different protocols. So you can see here the C1 protocol. We'll go back here. A1, sorry. Can we see that? All right. A1 is about 90% of the patients that you're working with today are going to benefit from this particular clinical protocol that was developed. So most of the time you're going to be using this for NMES. Then we have A2, and this is going to be a protocol typically used for a patient that might be obese or heavier set, where you need to have a deeper penetration into that muscle and into that tissue. The A3 protocol is for sensitive residents or patients, meaning that if, maybe the intensity of the 200 frequency that is actually set up for is too much, this is pared down a bit so that it's a little more comfortable experience for that sensitive user. And then we have A4, and this is used for facial stimulation. So this is going to activate those muscles in the face, and the placement of the electrodes are going to be obviously set up differently than as you would use it when you're using it underneath the chin, where Lindsay was mentioning before during part of her presentation. And then we have C1, and that's actually an opportunity for you to customize a protocol. So you have some flexibility here with this product in that you can develop a protocol that makes sense for this particular patient, or if you have multiple patients that can benefit from a little bit different parameters, you can set that up. You have that freedom to do so on this device. I'm going to just kind of go through the screens here. We have ETS, so that's your electrical stimulation. And here we can change some of the parameters just by pushing the little toolbar or the little gearbox here. And here I can go through and I can change the time, I can change the frequency and so forth, which gives me some flex as well. There's a gamification mode on here, and in just one moment we're going to talk about what that application is. But it's a great way to have an interactive experience for the end user to be involved in an activity that uses surface EMG. And then we have surface EMG. So this here too is an opportunity for you with this device to actually engage with the resident with that biofeedback. All right. Next, we're gonna talk a little bit about that gamification opportunity. So with this particular product, you have the ability to download an app. It's free, which is great, and you'd use your iPad, easily accessible via the Apple Store. You can just easily grab that and download it to your iPad. And then from there, you would get to a home screen, which we're going to show you here in just a second. And from here, I can actually access a bunch of different options. The first one, we have a couple options in terms of ways to customize it. I can create my work time ramp down and really make it custom to that particular patient. As you can see, it has Bluetooth connectivity, so it's actually connecting via Bluetooth to the handheld device so that I can use that in conjunction. And then we have here an EMG test. So this is a great way to baseline the patient and kind of understand where they are initially, and then use that throughout some of the games that are established within the app itself. The app has a force exercise, endurance exercises, coordination exercise. So you have a couple different options to choose from when you're wanting to engage with that resident. So we'll just show you a couple examples of what that looks like. So for force exercise, I'm going to show you here Travel the World game. And this is where as the person swallows or engages in that swallowing activity, you can see on the bottom half of the screen there, that's your threshold that was established during that customized testing at the initially when you get that person seated with you. And then from there, that's going to be their goal line. So they're going to, try to hit that goal mark, that max target. And as they engage in the activity, they're going to be competing with those other balloons that you see here. So I'm not connected to the system itself, so I can't show you me, competing, but I can at least show you kind of what that looks like. I'm the number 5. I'm last in place. But I assure you, if I had electrodes on, I'd be winning right now. If we go back for endurance exercises, here we have a facial interactive piece where, obviously if the stronger they swallow, the more facial expression is going to be positive. So again, it's that interactive experience for the end user so they can kind of see where they're at, and the harder they work, the more benefit they're going to see on screen. And then lastly, I'll just show you a quick example here of the dancing gorilla. And so this here, as I swallow, it's still that same experience. You see the threshold at the bottom, and as I engage those muscles, it's going to allow for me to swing that rope and knock down boxes that will then fall on these little images here. So you can see here, we've got boxes coming along the way here, and as I swallow, if I had been connected, I'd be able to swing that up, break those boxes down, and attack these various little characters here. So here we got a zombie coming after me. So it's kind of fun. It's interactive. I think at the end of the day, therapy as we all know, can be painful, can be difficult. You might have pushback from the patient. But if we can engage with that person and try to incorporate some kind of activity that's fun, that's interactive, that also entertains, you're going to find that you're probably going to have a better ability to not only connect with that patient, but also help motivate them to continue on with their therapy exercises. I will mention, too, that this app is completely contained, so that what I mean by that is that it doesn't have any patient information in it. So when we talk about HIPAA, it is compliant, which is also a very important benefit to this particular application. For training, if you were to purchase this product through direct supply, we have it set up in our system, and I believe a link that leads you to a product number that has both the product and that training component linked to that item number. The training is 1.35 ASHA CEUs. That's 13 contact hours. And that's led by Lindsay, who's fantastic, as you all have experienced now. And she's going to really, walk all of the SLPs through the various different applications of the product, of the app itself, but more importantly, all the general principles, all that baseline information, really getting back to the basics, so that there's a fundamental foundation there for prior to even engaging with the product itself. And what's nice about it is that following the actual coursework, which is a 2-day course, Lindsay will connect with each and every SLP individually to ensure that they have, a really strong understanding of the product and they feel really confident and comfortable going forward with it. The product itself, also the Aspire 2, has a couple different options for electrodes that I thought I'd mention. One is a standard electrode, which, typically with products such as the any product that allows for stimulation of the neck muscles as you're trying to work through functions like dysphagia, they're going to have electrodes that are only good for one-time use. And so there is that option, the standard option. And then there's another one that uses hydrogel is the name of it. And it's water infused, it's hyperallergenic, and it actually is approved to use 4 to 5 times with that particular individual. So it has a longer lifespan, a little bit more cost involved, but honestly, if you're only using an electrode one use per session, in the long run, the ROI is there, and it's a really great product in that it adheres comfortably, and as I mentioned, is hyperallergenic for those who are sensitive or have skin sensitivity. So that's what I have for you today. We're going to have, again, a link for you to follow up on that product and link to what that product cost would be for you. Your account manager also is going to be a great resource for you to reach out to for that pricing information. If you do have additional questions specific to the product and or to the Guardian Way, the protocol that was developed for this, Lindsay and or myself, we can jump in there and help you out and help you have a better understanding as to what this system all entails. So I thank you for your time and sticking around, and I'll see you all soon.
Thanks, Kelly. We did have one question that came in for you. Does the product only work with Apple products and iPads?
Yes, as it stands today, the iPad is really the one product that it is going to have the ability to connect to. I know that in conversations with Lindsay and her team, they are developing a synergy with other devices, and that's going to be happening relatively soon within the next handful of months. And if Lindsay, if you're on the line still, maybe you could help identify some of those timelines for additional connectivity.
Yeah, no, you had it exactly right. So right now it works with just an iPad. You can still use the Surface EMG and you can use the NMES with no device whatsoever. But if you want to do the gaming like Kelly was showing us, today's app works with just the iPad. Our newer version of the app should be out in the next 60 days. That will work with iPad and with iPhone, which we think will get it in the hands of more of our SLPs. Particularly since it doesn't require any special authorization due to HIPAA data or anything like that. And then after that, we'll be rolling it hopefully to the Android platform. And again, just trying to get it more accessible for all the different devices that folks might have.
All right. Thanks, Lindsay, and thanks again, Kelly. Thank you all for attending today. For more information about upcoming webinars or to view past webinar videos, please visit directsupply.com/webinars. Once again, thank you for attending today.